Okay, good evening, everyone. Thank you for joining NATF's online support group. We're really happy to have you here this evening. And we are delighted to have Dr. Gregory Piazza, who is a cardiologist and vascular medicine specialist at Brigham and Women's Hospital. He is here tonight. He doesn't have slides or anything. He's just here to answer your questions. So if you do have a question, you can either send them to me using the chat function if you're feeling shy, or you can click on the small hand icon that's to the left of your name, and that will quote unquote raise your hand, and then I can unmute your line so you can ask the question yourself. And with that, I'm going to go ahead and turn it over to Dr. Piazza.
Great. Thanks, Catherine. And thanks to all of you for attending this NATF online support group. Many of you have sent in questions, excellent questions, personal stories of your battle with blood clots, and I'm happy to go through all of them. As I was telling Catherine, I spent time today going through the printed form that I had with all your questions, making notes, and so I feel very ready to dive right in. And with that, I think we will do just that. I'm going to first address a question from Crystal. Crystal writes that she had presented several times to an emergency department with symptoms that were concerning for blood clots, and she had an evaluation that demonstrated a positive D-dimer test, which we'll talk about in a second, but that they weren't able to find any blood clots, and they told her to sort of follow up with her local primary docs, and she's kind of left with the question of what can I do and who do I see to help? And so this is not an uncommon problem. In some cases, patients will have symptoms that for all intents and purposes really do match up nicely with blood clot symptoms, and they don't end up having blood clots. And in those cases, we have to search for other causes of their symptoms. If they're chest pain or breathing type symptoms, we have to focus our attention on musculoskeletal problems, gastrointestinal problems, or pulmonary problems. If it's an issue in the legs and discomfort or swelling, we've got to look for other causes of swelling or musculoskeletal or neurological reasons for pain. Sometimes patients will have those symptoms and there won't be any clear-cut signs on testing of blood clots, but they'll continue to present to the emergency department and eventually a blood clot will be found. Those are less common, but they do happen. And sometimes it's just that the blood clot is too small to be detected, or there's no blood clot. It's just sort of pre-blood clot, which is slow flow through a vein and causing symptoms, but there's nothing they can actually see on the test. D-dimer is a type of blood test that's often done to rule out blood clots so that we can avoid keeping patients in the emergency department for longer, more involved testing. And so a D-dimer is a blood test. It actually measures sort of the breakdown products of clots. When clots are dissolved by our body, there are some byproducts that are produced that can be detected in this blood test, and those are called D-dimers. And when D-dimer is elevated, it may be a sign that there's a blood clot that your body's trying to break down, or it could be positive for any number of other reasons. Any inflammatory problem, like an inflammatory arthritis, or even a meniscus problem, or some other musculoskeletal injury with inflammation can raise your D-dimer. A simple head cold can raise your D-dimer. So one of the problems with D-dimer is it's not what we would call specific for blood clots. When a test is specific for a certain disease, it means that when the disease is positive, there's a very high likelihood, like in the high 90%, that the person has that disease. When a test isn't specific, then it means it could be positive if they have that disease, but it also could be positive when they have some other disease. And in this case with D-dimer, that's the problem. So Crystal, for you, I would continue to work with your local doctors to find out if there's some other reason why you might have those symptoms and why you might have a D-dimer. I find it very helpful to retest the D-dimer perhaps a month later to see if there was any inflammation. If the D-dimers return to normal, then that fits with an inflammatory or short-lived cause for the D-dimer being up rather than a blood clot. But the important thing for you, and I think the fact that you asked this question means you already know this, you have to keep plugging away with your providers to make sure we get to the root of your symptoms and why this D-dimer is positive. So, Crystal, I hope that answers your question. To summarize, I just keep working on it with your providers until you get resolution of what might be going on. Now, another question comes from Dorothy. Dorothy talks about a DVT or PE that she suffered a year ago, and she's been on Xarelto, one of the direct oral anticoagulants, 20 milligrams. And then her providers adjusted the dose of the Xarelto down to 10 milligrams. And we'll talk about why we might do that in some cases. Following that change in dose, she started having leg pain that was pretty difficult for her. And her D-dimer, when tested, was increased. And she was waiting for a leg ultrasound to be done. But her questions were really, one, if there's a rebound period when reducing blood thinner doses that might allow the clot to form again, and whether she should be back on the higher dose. So let's talk a little bit about Xarelto and a little bit about the dose reduction, then we can maybe come back to Dorothy's particular case. So Xarelto is one of these direct oral anticoagulants. It's an anticoagulant that works specifically on one factor in the clotting cascade, factor 10, and it's been really used for about a decade now. It may seem new, but it's really not that new. It's been used for about a decade for treating blood clots in the lungs and in the legs. The initial starting dose is 15 milligrams twice daily for 3 weeks, and then there's a reduction to 20 milligrams once daily to treat what we would call the acute or the highest risk phase of the blood clot. When patients finish that 6 months to 1 year of the sort of acute phase of blood clot treatment, some of them may be eligible for a dose reduction. These are usually patients with history of an unprovoked or provoked blood clot who have an increased risk for recurrent blood clots, but don't have particularly strong risk factors for recurrence. So if someone had, for example, a genetic predisposition to a blood clot that was known to be very strong, we probably wouldn't decrease the dose. We'd keep it at 20 because we would want something potent to overcome that risk. But it sounds like in Dorothy's case, she had a blood clot that made her providers worried about future blood clots, but she didn't have any of these red flag predisposing factors. And so they made a decision to drop down to 10 milligrams once daily. And that strategy was proven to be very successful in a study called Einstein Choice. In that study, the 10 milligram dose was very effective and particularly safe, which is, I think, one of the reasons when you're going to have a patient on a blood thinner for a long time, and it sounds like for Dorothy, they're planning on that, 10 milligrams and a lower risk of bleeding is a good deal. Now, getting back to Dorothy's particular case where she developed symptoms again after the dose was reduced, and it sounds correctly so, it sounds like that prompted workup to make sure she hadn't suffered a new blood clot or extension of the old blood clots. That's exactly what I would have done. She's had a leg ultrasound that she's waiting for the results. I would rely heavily on those results to see if we need to go back up to a higher dose. I'd want to make sure there's no other explanation for the return in symptoms. One of the things that happens after a blood clot in the leg is something called the post-thrombotic syndrome. And this is a complication of deep vein thrombosis where patients have persistent or recurrent pain and swelling in the lower extremities after a blood clot that oftentimes masquerades and pretends to be a new blood clot, but when you have an ultrasound, it just shows that there's the old blood clot and nothing new. And this is a difficult problem. It's something that keeps patients out of work and tortures patients who've had deep vein thrombosis. Compression stockings may not prevent this from happening, but they're certainly excellent for treating this. And hopefully Dorothy's taking or using compression stockings because I think that'll help regardless of the result of her ultrasound. For someone with a blood clot in the deep veins of the legs, we tend to use compression stockings in a strength of 30 to 40 millimeters of mercury. That's the strength. And we'd want to use either knee-high or thigh-high to cover the area that had a blood clot. And generally put those on in the morning, wear them all through the day, and then take them off at night to go to bed. And I found that in the first few years after a blood clot, that is a very helpful step for treating discomfort that could be the post-thrombotic syndrome. So for Dorothy, I'd get the results of that leg ultrasound. If there was a new blood clot, you probably will have to go back on a higher dose or perhaps a different blood thinner. If there wasn't a new blood clot and you haven't been using stockings, I would certainly look into that with your provider. That's a great question, full of really important topics such as dose reductions, post-thrombotic syndrome, and recurrent symptoms. Now, Scott tells us about a blood clot that he had in 2016 in his left leg after knee surgery. He got put on Xarelto for 6 months and then was taken off of it. And then, unfortunately, on July 4th of last year, he got diagnosed with multiple blood clots in his lungs. And there didn't seem to be a provoking factor to these blood clots. So his providers felt that these were unprovoked, and they put him back on Xarelto. They told him this was going to be for his lifetime. And then at some point, it seems like in early May, they also made this dose reduction from 20 milligrams to 10 milligrams. And so that is very similar to Dorothy's case, where she was down dosed. And again, that's based on the Einstein Choice study, which was a very important trial that came out a year ago, showing that that was a very reasonable thing to do. Scott further asked questions about his knee surgery, as he still has knee discomfort. And he was told that he could never have a non-steroidal anti-inflammatory drug like ibuprofen because he's on Xarelto and the risk of bleeding on these types of anticoagulants. Before he had his blood clots in the lungs, he had been on a different type of non-steroidal anti-inflammatory called diclofenac, which really helped his knee pain. And so he's concerned that he's not going to be able to use these anti-inflammatory drugs for treatment of his knee pain in the setting of anticoagulation. And this is an area where providers differ. I will tell you, for my patients that have a lot of arthritis and musculoskeletal pain, who are on blood thinners, if they occasionally need a non-steroidal anti-inflammatory drug to help with bad musculoskeletal pain, I'm actually fine with that. I will recommend that they use nothing higher than moderate doses of these anti-inflammatory drugs. They'll have to work with their providers who are prescribing these, but for example, ibuprofen comes in 200, 400, 600, and 800. I tell my patients to try to keep it in the 200 to 600 range and not to use the highest dose 800. I recommend that my patients use the non-steroidal anti-inflammatories as sort of for breakthrough pain, for tough days that they have. Let's say they're working in the garden the next day, they're having a lot of pain. I'm very comfortable with them using non-steroidal anti-inflammatories at that time. I don't want them using it for weeks at a time, but if they have a few days that they need to use it, I'm okay with that. And so I let my patients use moderate doses a few times a day for a few days in a row to manage their pain. And my experience is that that's worked very fine for them. Some of my colleagues, like Dr. Goldhaber, who's the president of NATF, doesn't allow his patients to use non-steroidals under any circumstances. There are no studies, there are no clear-cut data that say you can or can't. So I try to give my patients a little bit of leeway to get more comfortable. Certainly, Scott, you can talk to your physician and see if they're comfortable with using non-steroidals in the way that I let my patients do. Otherwise, you may consider going to a pain clinic where they can use other means for controlling your pain, such as injections of steroids into the joint, analgesic patches, other types of medications that work on nerve-related pain. There are a number of ways. The bottom line is you don't have to sit there and suffer in discomfort just because you're on a blood thinner. Now, Patty sent in a wonderful question. She starts off by telling about her story of a first pulmonary embolism in 2004 that came after a surgery. She had a filter, an Ivc filter. We'll talk a little bit about that in a second, placed. And then, amazingly enough, 14 years later, she got diagnosed with blood clots in her lungs, and she had a clot that they could see below and above the Ivc filter. So they put her on Xarelto and told her that it would take a while to dissolve these clots. She's had a little bit of trouble with bleeding on the blood thinner and worries that if she gets to the point where her bleeding so much that she has to stop the blood thinner, how would she be protected from blood clots? And some of her doctors suggested that she may need a second Ivc filter to be placed above the first one that's still in there. And she raises a really great question about whether that's really her only option. And she speaks to the same gut reaction that I had reading her question. And she's a little bit wary about a second Ivc filter, and I would be too. So let's talk about Ivc filters. Ivc filters are, you can think of them as metal baskets, or literally like filters or a colander, something that you might use to strain pasta, that gets put into the inferior vena cava, which is the big vein that takes all of the blood flow from your legs and brings it back to your heart. It's placed very easily just through a catheterization procedure. They don't need to open you up. They just place a needle and a little catheter in a vein in your leg. This thing is all folded up like an umbrella. When they get to the point where they want to release the umbrella, they do so, and it expands pretty much like an umbrella and kind of stays put and catches any blood clots that might try to go to the lungs or to the heart. These devices do work great for protecting patients from blood clots in the lungs in the short term. One of the things we've learned about these is that we have retrievable ones that we use almost exclusively now. These are ones that can be put in and then pulled out. And one of the things that we've known and learned about over the last 5 to 10 years is that a lot of these filters are put in with the intention of retrieving them and never pulled out. And when they sit in there for long periods of time, they can have an increased risk of complications. These filters sometimes can develop clots in them, in which case they no longer really protect the patient from blood clots in the lungs. they kind of sort of serve as a nidus for, or a point where blood clots can form and then grow, and that can increase the risk of blood clots in the legs and lungs. Sometimes pieces of these filters will break off and travel to the lung, and then those little pieces have to be fished out through procedures. Or other times they tilt or protrude through the wall of the inferior vena cava and poke things that they shouldn't. So the bottom line is, when we put these filters in, we want to take them out if we can. That's really one of the most important things, is putting them in when they're needed and taking them out as soon as they're no longer needed. Now, it sounds like in 2004, we did have retrievable filters, but we were also still using permanent filters. And so it's possible, Patty, that you received a permanent filter and not one that we could remove. Either way, now that this filter has developed blood clots, being on a blood thinner is the correct treatment, especially given the fact that you also had blood clots in your lungs. As a general rule, we're very reluctant to place a second level of filter like you've had placed, like they're proposing for you, because usually the original filter is placed in the best location possible. And other locations that are left over are suboptimal. In this case, placing a filter above the filter that you already have would mean placing it above the veins that could break off to go to the kidneys. And if the clot in the first filter were to extend to the second filter, and anytime you put a foreign body in the vein, you run that risk, you could possibly clot off the veins to your kidneys, and that wouldn't be a good thing. So I can tell you, and I've been doing this, especially this type of clot work, for about 15 years. I've never put a filter or asked for a filter to be placed above another one. If you do start having a massive bleed and are unable to take a blood thinner, then that's something that may be discussed, but hopefully you'll be far enough out from your blood clot that they wouldn't need to do that, or they can find some way to attenuate the bleeding. But I would just say in closing that I would be very wary about a second IVC filter, and I would try to exhaust every possible other channel before relying on that. So that was a really good question and a very nice way to talk about IVC filters. Now, Gus chases a question of his wife having a right hip replacement last November. She had a very complicated course after this hip replacement. She had a big seizure. It was suspected to be due to encephalitis, which is a type of inflammation, oftentimes an infection of the brain matter, but they weren't able to find the cause. They couldn't really, despite testing, localize a reason for this. She got treated with medications, and in this sort of recovery period, when she was dealing with this major neurovascular or sort of neurological issue, she developed blood clots in her legs and in her lungs. She was put on heparin and some anti-seizure medications and steroids. She's had a very complicated course. She had a very complicated course after that, and at some point they did a biopsy and found that some lesions that had shown up on her brain were actually malignant. And sadly, she went home under hospice care and died peacefully in May. And his question is whether undetectable PE resulting from her hip replacement could have traveled to her brain, caused brain swelling and seizures, and eventually tumors. And I can tell you that I've never heard of such a thing. These types of glioblastoma tumors tend to come up on their own. We don't have a good understanding of the risk factors for these tumors, but certainly they are not the types of things that are the result of blood clots in the brain or blood clots in the lungs. Typically, blood clots in the lungs can't travel to the brain. There has to be a hole in the heart to allow them to leave the right side of the heart and go to the left side of the heart and travel to the brain. And when they do that, they cause strokes, but not brain tumors. So this is one of those cases where we try to look for a unifying cause, something that ties together all of these difficulties that a patient has gone through. But the truth of the matter is sometimes there really are multiple processes going on at the same time. And I don't think there's a thread that ties together the PE with the tumors. It's just two very unfortunate circumstances. I do think it's possible, though, that the tumors could have resulted in the pulmonary embolism. We know that tumors in the central nervous system produce a lot of proteins that cause the blood to thicken, and we do see a lot of DVTs and PEs in patients with brain tumors. So while the PE probably didn't cause the tumors, there's a good chance that the tumors caused the PE. And so that, I think, covers all of the amazing questions that I received and was able to think about. I hope I answered your questions. And Catherine, have you received more questions for us to talk about?
We sure have.
Oh, goodness.
So,
okay. Well.
Yeah. You've already covered a lot of ground. So, but yeah, we've gotten a couple other questions in. The first one is from Howard, and he wants to know, what time of day do you think is generally best for taking Xarelto? He says, given his lay understanding of the process and how the body forms and metabolizes clots, Xarelto's action mechanism and relatively short half-life in the bloodstream and clotting risk factors, I wonder whether this stoic could do more good if ingested with in the morning or with an evening meal. Is it better to take it in the morning so that the blood level is highest while body is more vertical and active, or in the evening so that the blood level is highest while the body is horizontal and relatively inactive?
No, that's a great question, and it gives us the ability to talk a little bit about some of the peculiarities of these direct oral anticoagulants, specifically Xarelto. So the way the studies were carried out on Xarelto, it was recommended that Xarelto be taken with food to aid in its absorption. So certainly, regardless of what time, Howard, you take the medication, I think with food is always a good idea. That's what your pharmacy will tell you. That's what the package insert will tell you, and then that's how the studies have evaluated this drug. Most of the studies have mandated that it be taken with the dinner meal, and that's what the package insert says. But I have some patients who have dinner at very irregular times. One day it might be 4, the next day it might be 10, but they have breakfast at the same time every day. In that case, I think it's very reasonable to take Xarelto in the morning and with your breakfast, so that you have consistent exposure to the medication and you don't have periods of time where you're actually late to take the medication. So I feel like whichever meal is most regular for you, that would be the best time to take Xarelto with food. Now, it's very interesting. You mentioned how Xarelto is a short half-life medication. Xarelto actually has a 12-hour half-life, which is short, and that's only half a day. And we only take Xarelto once a day, right? In the maintenance phase, we take 20 milligrams once daily. So some of you on the call might be wondering, well, Dr. Piazza, doesn't that mean that I have 12 hours where there's no effect of the Xarelto? And at least based on the pharmacology, which is the study of how drugs are metabolized and cleared from the body, that's true. The peak effect occurs within 1 to 2 hours of taking the Xarelto, and then the drug is in the system for about 12 hours and then starts to fade off. And so there's certainly some period of time during the day where there's little effect from the Xarelto. Now, with that being said, the medication's incredibly effective at preventing blood clots and treating them. When you compare it with warfarin, which is a drug that's taken and gives you an increase in your INR, which is the blood level that we use to monitor warfarin. Patients have INRs that are increased throughout the day. They don't have periods of time where there's a low INR. And yet, Xarelto is as effective, if not more, than warfarin. So what this really challenges is a whole series of assumptions we make. We've made assumptions that patients actually need to have their blood thinned 24 hours a day. That actually may not be true. It may be that we need our blood to be thinned for part of the day, and then for the other part of the day, we need our blood to return to some level of thickness so we can patch up any little bleeds that might have formed during the other 12 hours. And it may be that the reason that Xarelto is so safe, it may be that you have 12 hours where your blood's thinned and any clots that are trying to form are stopped dead in their tracks. And then the next 12 hours, when the medication's worn off, you actually are healing up any areas, any colonic polyps or any areas of ulceration in your GI tract that might have started bleeding microscopically. Those get patched up and closed while you're off of the blood thinner, and so you never suffer any bleeding. And we're now having to go back and think about whether all these assumptions are actually right about blood thinning. But I would say, to summarize, take it when you think you're going to be most consistent with it, take it with food, and I think that'll be your best bet.
Awesome. Thanks, Greg. And Howard did have one other brief question. He wants to know. He did. He's
Doesn't
asking.
that cost extra?
It does. Yeah, we'll send him the bill. He wants to know if hydration level affects either the propensity to form clots or rate of natural clot dissolution.
Absolutely. We've, in the last year or two, learned that dehydration is a very important provoking factor of blood clots. As a matter of fact, a lot of the blood clots that we in the past have attributed to long-haul air travel, when we've looked at long-haul air travel in patients that have a similar hydration level, really doesn't seem like that's a risk factor. What actually might be the risk factor is the fact that patients get dehydrated on planes or on long car rides. So dehydration is a big problem, and staying hydrated is one of the best ways you can prevent a whole host of medical problems, including blood clots. Great question. Maybe we'll let him have that one for free because it was such a good one.
Okay, good. Anne said that 2 years ago she had a DVT in her lower right leg, and she quit taking warfarin a month ago. And she would like to know if the redness on both lower legs and feet will ever go away.
Sure. So it'll depend on why there's redness. If I guess one of the questions is whether she had blood clots in both legs or one, and whether she has varicose veins in any of those legs. I will venture a guess that the redness is there because of a combination of having had blood clots and perhaps some age-related venous insufficiency. As we get older, and I don't know the age here, but as we get older, our veins don't function at 100% efficiency, and the valves inside our veins that prevent backflow of blood don't function as well. And so they can allow higher pressures in the veins in our ankles and lower legs, and that can lead to that reddish, sometimes brownish discoloration. I think if you can use compression stockings and you don't suffer any more blood clots, you can see an improvement in that color change. In some patients, it improves a lot. In other patients, it improves a little. Kind of depends on how long it's been there and what are the other causes for it. The good news is stockings actually help for both blood clots and venous valve problems. Good question.
Okay. Carol is, when she was set up to do self-testing at home for her INR, they wanted her to test weekly, but her primary care physician is upset and wants her to only test once a month. But she would like to keep self-testing because it helps her stay in between a 2.0 and a 3.0. And she was wondering what your opinion was on frequency.
Frequency really depends on a number of things. One is the ease or difficulty with which the patient can keep the INR within the target range. So in patients who have a difficult time keeping the INR in the target range, you may need to test more often. In patients who, and believe me, there are patients out there who have an incredibly easy time regulating their warfarin. They don't need to do it as often, and there have been some reports of patients only needing to test 4 times a year, and they do quite well. Other situations where you may want to test more frequently is when you're shooting for a target range that's different than the conventional target range of 2 to 3. If for some reason you have a restricted range where your provider wants you at like 2.5 to 3 or 2 to 2.5 or 1.5 to 2 or 3 to 4, all of these sort of alternative ranges oftentimes will need more frequent testing. Certainly, home testing, when you're doing that kind of home testing, it's a bit more up to your discretion as to how often you're going to want to test. And if your anticoagulation management service wants you testing once a week, then they're the ones who are actually doing the heavy lifting, the heavy work to help you dose. So I would lean towards making them happy rather than your primary care doctor, because if your primary care doctor is not the one directly managing the warfarin, they may not know all your numbers. They may not have the experience that the anticoagulation management clinics may have. There may be a darn good reason why the anticoagulation management service wants you testing once a week, and I wouldn't discount that at all. Those anticoagulation management services are usually run by incredibly bright people who really know warfarin and really know blood thinning, and usually I would place my full confidence in them.
And I would just like to add to that, I recently took a call with a home testing company, and I guess Medicare is really starting to push back on reimbursements for home testing. So that might be a part of this too. So you might, if you keep having problems, you want to call your insurance company and just see if that has anything to do with the situation.
Yeah. Good idea.
And a question from Diane, and stick with me for a minute. She's got a complicated case. So she's a 69-year-old woman who's diagnosed with a DVT of the lower extremity with the thrombophilia HC code. And this was in November 2017. She considered herself in good health and she's not overweight. She was treated with Eliquis for 3 weeks, and she went for a follow-up ultrasound and the clot was gone, so she was told to stop the Eliquis. She does fly frequently between coasts. So then in February 2018, she noticed she was short of breath and went to see her primary care, who sent her to the emergency room, and she was diagnosed with bilateral pulmonary embolisms. She was treated with several medications, including heparin, and this will make you happy too, Greg. She underwent the ECOS catheter, part the clots, and then she had a CT angiogram of the abdomen and pelvis to look for possible causes of these. They were negative for any disease. So now she's back on Eliquis 10 milligrams for 5 days, 2 times per day, then 5 milligrams 2 times per day. So 10 milligrams for 5. Yeah, okay. And she's currently on that dosage. So she did see her cardiologist. Her heart appears normal. In May, she had a follow-up D-dimer of 0.66. And then in June, she had a follow-up D-dimer of 0.032. So her question is, does the her DOO2 algorithm,
Mm-hmm.
she would be a candidate to stop Eliquis as she seems to meet the criteria except for her age.
Yeah, so what she's talking about is the HER2 score, the scoring system to help you identify patients that might be able to come off long-term anticoagulation. That is, I would tell you that we talk about that scoring system in conferences a lot. I don't know too many clinicians that actually use it with their everyday patients. Let me go back over how many blood clots she had.
So in November 2017, she had a DVT in one of her legs. And then
And was that provoked by anything?
I'm sorry, say that again?
Was that provoked by anything? Like, was it in surgery or?
No, it seems like it wasn't, because she said, up until this incident, I considered myself in good health and am not overweight.
Okay.
And then she had, in February 2018, she had bilateral PEs.
Yeah, so a little bit of a different type of patient than is typically thought of as someone who could kind of have a HER2 score calculated. The first blood clot sounds like it was unprovoked. Many of us would recommend long-term anticoagulation based on that, but if you wanted to do a HER2 score, you could, and you may stop anticoagulation. The problem is now she's had a second, more serious blood clot in the lungs, and that one also, was that one unprovoked?
I think so, except she says that she flies a lot.
Yeah, flight is not a risk factor. Yeah, so now she's had two unprovoked. Most of the guidelines would recommend extended lifelong anticoagulation for that.
Okay. So we got
the first recurrence, shame on, it's bad luck, but to let her have a third blood clot would be really shame on us.
Yeah. And is the HER2 score, is that something that's relatively new?
No, I think it's probably about 5 years old. You know who loves that? Jeff Barnes loves that score.
Oh, interesting.
Yeah.
I had never heard of it till this evening.
Yeah, we don't use it clinically, but some people like it a lot.
Okay, very interesting. All right, so we got one other question that just came in that they wanted me to ask anonymously.
Sure. Okay.
And this is a woman. She's had PEs twice, multiple PEs both times. And her lung scan showed hyperinflation of the lungs. She's a non-smoker and has no other chest conditions. Could her PEs be causing this?
Hyperinflation of the lung. And so typically that hyperinflation of the lungs is not something that is related to pulmonary emboli. That's something that could be due to any number of different sort of more lung or pulmonary based issues. The most common cause of that kind of finding would be some kind of reactive airway disease like asthma, or if someone had smoked for a while and had emphysema or chronic bronchitis. Some other types of airway issues can cause hyperinflation. Usually not PE though. Now, patients who have underlying lung disease are increased risk for PE, so there's always the possibility that the two are related, but not in the way that she thinks. It might be the fact that the lung issues and the hyperinflation may be a sign of lung issues that led to the PE, but not the other way around.
Huh, interesting. Okay, and then the second question she had, this is another 2-for-1, is she had a cardiopulmonary exercise test due to her significant decrease in exercise tolerance since her PEs. She used to be able to walk 10 to 15 kilometers, no problem, still have energy. Her maximum now without resting is about 3 kilometers. Then she has to start walking slower and sit down. However, the cardiopulmonary exercise test showed findings do not indicate any significant exercise limitation. The cardiopulmonary response to exercise were largely within normal limits. But she said she gave 150% and felt like she was running a marathon and collapsing at the end. The clinical picture is not included in the report. Could you please elaborate on anything here to help me understand?
Sure. So two things that we can kind of talk about here. One is what happens to patients after blood clots. So there are kind of two main complications of pulmonary embolism. One of them is called chronic thromboembolic pulmonary hypertension, which is when we have pulmonary emboli that don't break up completely, even with the blood thinners. So you still have some old chunks of blood clot in the pulmonary arteries. And then on top of that, you get release of hormones that actually make the pulmonary arteries squeeze and get narrow. That can lead to high pressures in the pulmonary arteries, and that can make people very short of breath. That would show up in an echocardiogram. That should show up on the cardiopulmonary exercise test that she had. Her doctors may have done another CT or a VQ scan or something. I can't remember if you mentioned that, to see if there are blood clots that remain that haven't been dissolved. So that's one of the things we look at in someone who describes the symptoms that she does. The other complication is something called the post-pulmonary embolism syndrome. I would think of this as something that's more mild or milder than the chronic thromboembolic pulmonary hypertension. And what it is it's a decline in exercise capacity after a blood clot that doesn't get better quickly enough. And so patients either have much more limitation than they would expect to have, given the time that they've had to recover from the PE, or they never actually get back to where they were before, and on echo they don't have signs of any high blood pressures in their pulmonary arteries. We're just starting to understand this particular thing, but if I heard a patient of mine complaining of these types of symptoms, what I would do is, at the Brigham, we would have her undergo one of those advanced cardiopulmonary exercise tests that are done in our dyspnea center. Dyspnea means shortness of breath. We have a special sort of division of our pulmonologists that's focused on shortness of breath. And they do a special type of cardiopulmonary exercise test, which is actually not limited to the Brigham. Many centers have the capability of doing this. And it requires a couple of small catheters to be placed. And they basically measure your whole cardiopulmonary system while you exercise. And 95% of the time, they can tell you exactly why you're short of breath. Some of the things, sometimes it's just that you're very deconditioned after the pulmonary embolism, and you need to push yourself harder to gain back your stamina and your conditioning. These pulmonary emboli are actually substantial hits to anybody's endurance. Even if they're 18 years old, they can have huge declines in their exercise capacity. I've seen professional athletes that suffer pulmonary embolism that can't even get back to an amateur level because of this kind of limitation. Other times, there may be some completely other reason for you to be unable to do the exercise that you used to, some airway or pulmonary problem that the pulmonary embolism just unmasked. So that's usually what we do. We do these cardiopulmonary exercise tests where we look at the lungs and heart and the reaction to exercise, and we can figure out exactly why there's shortness of breath. And that's what I would suggest. If you can talk to a pulmonologist or your heart doctor about seeing where you could get one of these tests, or if you could see a pulmonologist that specializes in shortness of breath, that would be a good start.
Okay, and I would just like to encourage this patient, if they would like to learn more about CTEPH, we do a quarterly online support group with Dr. Bill Auger out at UC San Diego, who's really, I think, regarded as one of the world experts in CTEPH. And we do have recordings of past groups with him on our website, and he does a really good overview of CTEPH and, you know, kind of what the conversation you should have with your doctor is like. So that might be an additional resource for you as well. And then we have one last question, Greg, that is now Howard really owes us, because this is a third question, but he was just hoping you could elaborate a little bit more on, does body position, so laying down or standing up and being active, does that have any effect on how the DOACs would work in, you know, his body?
Not that's been studied or shown in any of the studies. So patients could do what in the studies could do whatever they want. I've had my patients take Xarelto at night. I've had patients take it during the day. I've not seen any higher failure rate one way or the other, or success rate. So as far as I know, there's nothing related to position.
So the big thing is really just take it with food at the same time every day.
Yeah, roughly the same time. Like if it's within an hour or two, that's great. I just have sometimes patients who take it at, they take it for dinner, and sometimes dinner's at 4, and other times, they may skip dinner and forget to take the dose or something. Just try to be consistent.
Okay. Awesome. Well, that is all the questions that we got. So thank you so much, Greg. You really covered a lot of ground and
Sure.
gave a lot of really great, thorough answers to these important questions. For those of you that did have questions or just kind of want to revisit this, we do record all our online support groups. So if you missed anything, don't worry. We'll have it posted on the NATF website by the end of the week, so you can always go back and reference it. And we are taking a summer break in August, but we will be back on September 18th with Dr. Umberto Campia, who will be talking about peripheral artery disease and what your legs can tell you about your heart. So this is a really hot topic right now in cardiology, and I think it will be a lot of interest to everyone on this call. So thank you so much again, Greg. This was wonderful.
Sure.
And thanks everyone for joining, and we will talk to you in September.